Hello, and welcome to this webinar on demand and capacity modeling for post-COVID-19. We'll be talking here about your demand and capacity journey, some first steps into how you might start looking at applying some modeling and how that might relate to modeling for your service as it goes into its recovery phase. Just to introduce myself, my name is Keith Khunpha. I'm the technical lead for the demand and capacity program at NHS England and Improvement, and with me today is Rob Aherne. Rob, would you like to introduce yourself?
Hello, everyone.
Lovely. Thank you, Rob. So what we're going to be talking about today, the exam question is, how do we model demand and capacity so that we can plan effectively for services post-COVID-19? And how can we use some of that information in the context of our greater management of services to effectively make sure that we are treating our patients safely? In the context of this analysis, we'll be looking at elective care, non-overnight stays, and I'll be talking very quickly just before we begin with Rob to look at some of the factors that might be affecting your modeling. So in the first instance, when we actually talk about modeling, things will obviously have changed with COVID-19 affecting the country and healthcare services. So you'll need to account for factors affecting your demand. Now, historically, we would have looked at historic demand and used that as our baseline, assuming that there haven't been changes and go forward from there. That's obviously not the case. So as you can see with this small chart here, there'll have been some suppression of demand as elective services have paused. At some point, we assume that they reopen and they'll be coming back. And as a first point, we take our historic baseline as the point that we would expect demand to come back to, on the understanding that things might have changed. So there might be some other factors that we really need to think about. The other thing to bear in mind is that you might have an existing backlog on your waiting list, and there might also be the patients who you would have normally expected to have seen during the period where demand is suppressed. They will also need to be registered in some way, and we expect them to come back into the service at some point. So there's potentially an extra lump of demand, so to speak, that you might need to account for when you're considering the reopening of your service. Now, for both baseline historic demand and for your backlog, we can do something in terms of looking at the data to get an idea of how big that might be. There are some other aspects which we probably won't have the data for. So things like what will the rate of return to this to a normal baseline level actually take? So that could be a relatively short period. It might actually spread out and take a bit longer. There might even be additional periods where we might be reimposing restrictions to service due to a second spike in COVID, for example. So those are things that we don't really know in terms of, or that we won't really have very much information about, but it's worth bearing in mind as part of your contingency planning. And once again, Rob will probably cover some of this stuff in just a few minutes. The other aspect that we need to think about is what the new level of normal might be. So that might be affected by, for example, changes in your demographics. There might be changes in acuity, as well as changes in behavior of your patients. So in terms of a reluctance maybe, or right caution to be going out to public spaces might increase the level of non-attendances, for example. So these are things that would affect your demand, and you might need to bear in mind in terms of planning for your service. The other half of the equation is looking at capacity. So once again, we can look at baseline historic information that you may have as a starting point in the absence of anything else. So what you had available historically, if there was any transformation plans that were in progress, and that helps to inform what your starting point might be. But looking forward from there might be other things that you need to bear in mind. So things like pathway changes. So if you are reworking your pathways, if you are changing your mode of contact, so if you're increasing the amount of teleworking, for example, or video conferencing to get in contact with your patients, that might change just how the pathways work and also the rate at which you can actually see patients. There'll be also some consideration that you'll need to make about upstream or downstream dependencies and how that might impact what your service is able to deliver. And finally, of course, there's also the absence rate that you might be expecting for your staffing because of, for example, shielding or illness. So, but quantifying both of these aspects, your demand and capacity, will be a key part of managing the information and using that to risk manage your service going forward. So now I'll hand over to Rob, who will talk us through how you can actually use this information, how you can use modelling to support your service restoration and recovery.
Thank you very much, Keith. Hello, everyone. As Keith mentioned, my name is Rob Aherne. I'm the Information Analyst at Shrewsbury and Telford Hospital NHS Trust, who is responsible for demand and capacity modelling. I've been doing D&C modelling for a little under 5 years, using the majority of the tools provided by NHSI, the D&C team in particular, and some other things that we've developed internally to meet our specific requirements. When it was announced that the majority of elective services were being stepped down as a result of the emerging pandemic, I had to think about what we were going to be needing information-wise to switch everything back on. Obviously, that was going to be an unknown as to when that was going to happen, but we knew at some point it would be happening. So I'm sure you all found yourselves in the same position I was in at the time, wondering, where do I start? What am I going to need, and how am I going to be able to get it done with all the other pieces of work that no doubt are going to be heaped upon the pile in the coming weeks? I like to consider myself a bit of a problem solver, so my natural thought process was not only to think about what would be needed to accomplish the specific task of modelling the restoration, but also, if I was going to be doing all of this work, what else could I use that information for? Why repeat the process for something else? Who else could it be useful to? So that is why we are here today. Firstly, we have a slide up here which shows at our organisation we set up a recovery steering group and a series of subgroups to work on the individual areas, but they all carried the same core principles for consideration. As you can see here, the key one, I'm sure everybody is having to do the same, social distancing, how that would be affected by the logistics of our estate, the timing of the events to ensure adequate patient flow, and the targeting the maximum level of restored capacity whilst maintaining patient safety and staff safety. We had to ensure PPE usage was calculated, sourced and supplied to minimise disruptions to the services that were being restored whilst maintaining adherence to the law. We had to ensure that both pre-admission and post-discharge patient testing was being accomplished to ensure high utilisation rates for the capacity we were restoring, as well as protecting staff and aiding in the contact tracing process if that became necessary. We also had to make sure that those staff involved in restored services who were deemed to be at risk due to the nature of the service they were restoring were routinely tested to minimise the threat and potential for outbreaks and try to cut down on any enforced closing of services. We had to, excuse me, I just jumped ahead one. I'll just move that back. Apologies, the slides seem to have a life of their own at the moment. There we are. We also had to make sure that we controlled any potential infection risks to minimise threats of outbreaks and infection of the patient and the staff. And finally, we're making sure that any other services that were involved directly with or even indirectly with the service restoration were not forgotten. Anybody who was involved as part of the bigger picture, we had to make sure they were involved in the decision making and were able to identify and provide resources to make the restoration plans a success. Now, each of these areas generated a lot of individual ideas, but I was looking for those areas of most benefit which I would be able to build on quite quickly and without having to build some form of complex system of tools to support and inform them. So this brought me back to the tools that we were already using, specifically the D&C models, and in particular the new service restoration models that Keith alluded to earlier. Thank you very much, Keith, for developing those, by the way. As Keith mentioned, this model has now been published for use on various platforms, so I spent a little time going through it and seeing how it could help with the work I was expecting to have to start doing in the near future. I was quite impressed with the ability to use our own figures for forecasting, because that's something we'd not been able to do before, and the fact that we can now build the individual capacity elements to match those required levels was quite useful. It allowed us a lot of flexibility in what we were going to be doing moving forward. That therefore allowed better planning when modelling our services and will give us a better idea of what we could expect coming up in the future. Now, as you all know, modelling at this level is not as precise as we would like, And we have to make a series of educated assumptions using the data that is available to us to inform the models and therefore affect the underlying calculations. Given the unknown future of both the virus and what our response to the outcomes would be, it was best to make a decision that we were going to run multiple versions of the models, accommodating a series of assumptions that we were going to make. So using this multiple scenario approach, we could match real-world outcomes to our models and help identify which assumptions we'd made were more accurate, and then use those assumptions rolling forward in any new models that we did build. So therefore, that would then allow us to add a further set of assumptions and hopefully fine-tune our process. Repeating this process every few weeks would therefore allow us a much greater understanding of not only how the virus was developing in our local area, but also how our services could and would respond and adapt to how the patients were going to be treated. Now, I'm sure you're aware that this is going to be a lot of work. It is a lot of work. We're trying to do it at the moment. It does require dedicated resources, but ultimately it would leave you in a much better position to handle any service adjustments and fine-tuning should that dreaded second wave emerge. Modelling in itself should never be done in isolation. It's not the be-all and the end-all of the process. It is just one of a suite of tools and processes that should be utilised to better understand the pathway of a service, the drivers and the results of the decisions made. If you are going to build multiple models, then they need to be operationally managed correctly, built by everybody who's involved in the process, and hopefully, if everything works out correctly, be quite accurate and prove that you are fully aware of what is going on within your service. That in the end brought me back to the basic question of what is in the models that we can use to help answer bigger questions. So I opened the latest version of the model that Khunpha provided, stared at it for a while, closed it down, went and did something else, came back, opened it again, stared at it a little more and closed it down again. I really wasn't having much of ideas as to how I could utilize it. But then when I was actually working on a completely different problem, I had that light bulb moment that comes to all of us at times. And historically, in demand and capacity modeling, we focused on the demand. That is why it's the first word in the title. It's been the key driver in what resources we need to make available to best treat our patients in the most time-appropriate manner. But now all of a sudden, we have to shift focus. Demand was always going to be there. It was not going away, even if it was reduced on a week-by-week basis due to the reticence of the population for visiting GP practices or even attending hospital. It was always going to be there, and it was always going to outstrip the capacity that we could put in place given our new requirements. At some point in the future also, it would return to the normal pattern, more representative of pre-COVID levels, but we couldn't tell when that was going to be. So if we had an unknown in the demand, we had to look elsewhere as to what we could do. That therefore meant that capacity became the main focus. How many people could we treat safely and in accordance with all the considerations I've mentioned earlier? So with that in mind, we focused on capacity. How could we use the capacity to inform the other processes across the trust? Capacity, be it appointments, tests or theatre slots, would directly translate into patients. It would also be able to identify the staffing levels required, such as consultants, nurses, HCAs, clinic and theatre staff, and from that, if necessary, the volume of staff testing that would be required. If we knew we were putting on 4 clinics and each of those clinics had a consultant and 2 HCAs and an admin staff member, we knew how many people were going to be at a potential position for contamination and therefore may require testing. It would also have a bearing on the type and amount of PPE needed for both staff and patients. If we could tell the number of staff members who were going to be on, we could tell how much PPE was going to be required. If we knew 45 patients were coming in over the day, we knew that we would need 45 masks at the front door. On top of that, the number of patients on an admission list became the number requiring pre-admission testing. So once we knew what our theatre slots are going to be when we restore our services, that will tell us how many patient testing or how much patient testing is potentially going to be required, and we then make sure that we have that resource available. On top of that, the book capacity could also give you an idea of the volume of people who would be on site on any given day. and whether this exceeded an identified safe level for adherence to social distancing, as well as where they would be precisely and when they would be there, which I will cover in a little bit more detail a bit further in. And ultimately, that PPE that was being used would become clinical waste. Much more waste would normally be generated by the pre-COVID operation of the service in question, and there would be the added complication that this waste could be deemed contaminated and would require additional precautions on collection and disposal. All of this PPE that was being used would require replacing. It would require sourcing, procuring, delivering and supplying to the clinical area where it is to be used at the right time and in the right volume. And within each service being restored, there would be equipment that may be used and would require cleaning and decontamination. Each capacity element being restored should be able to list what this equipment is and what cleaning schedule would need to be put in place and how long that would take the equipment out of circulation, and also whether it would impact on the delivery of the service. If you were to list this and provide the details to your IPC team, they would be in a position to create some form of effective cleaning protocol, which would hopefully minimise your downtime and may aid in identifying the volume of replacement equipment needed to maintain a sensible level of continuation of service. Now, I need to make it clear that whilst all of these things can be informed by the model, the last one is the only one that can actually be directly recorded in the model. This can be done through the capacity planning process, where you identify the critical resources and the timeframes of which they are out of use. That will then downgrade your available capacity. So that's something that can be done within the models, but everything else would need to be taken out of the models and calculated separately. Okay, so in order to work out everything that I have just mentioned, you're going to need a lot of information from other sources. Information that is already likely to be out there, but they may not actually be passing it around. It may not be being shared. They may not think it's relevant to other services. It is relevant, and hopefully you'll be able to get access to it. So, as mentioned earlier, any service planning on restoring should be able to identify the staffing numbers and the roles associated with every capacity element that they are bringing back online. This would include frontline and ancillary staff that may potentially have some form of contact with the patient. If they are able to do that, then the clinical leads, working in conjunction with your infection control teams, should be able to provide you with a breakdown of PPE requirements for the various capacity scenarios, as well as the specific type of PPE needed and the frequency of replacement. These two measures alone will help you work out precisely what volume of PPE is required for any service that is restoring and how to protect both patients and staff. This can help make sure the service has sufficient volumes of PPE in the correct locations to minimise any disruptions through shortages, and can help ensure sufficient masks, etc. are made available at the point of entry for patients entering the site, so you don't have any problems with people unable to access your resources. The next step is the logistics side of the process. It is possible to plot the restoring capacity resources, be they clinics, testing suites or theatres, onto a map of your trust estate to best identify the points of entry and egress, thereby minimising congestion. As more and more services return to an operational standing, the aim here is obviously to identify where people are going to be coming in and out, and whether, if everybody turns on a service that uses one particular door, how you're going to cope with that. The current NHS estate, unfortunately, was built or wasn't built with a pandemic in mind, so we are going to have to change how we see it and how we see corridors, clinic rooms, doors and car parks. In pre-COVID times, the majority of patients were funneled through a few key areas, through main reception areas or main entrances to your hospitals. With social distancing to the fore, this is going to need to be addressed. It may no longer be possible to make wholesale adjustments to how patients move around your site because of other restrictions that are in place, but knowing where they are going, how many there are and when they are going to be there may allow you to change some elements of the patient flow to minimise this risk. Obviously, if this is going to be a requirement, working with estates is going to be key here, and early notification to estates may mean that you are not delayed in doing your service restoration. On top of this, infection control protocols will need to be adhered to ensure any equipment used directly or indirectly is maintained to a safe level, and your IPC teams will be able to support you in identifying what needs cleaning and how often. Now, all modelling requires data, as Keith has alluded to earlier, which brings us to the service metrics you are going to need to support your D&C modelling. You will need to work closely with your informatics team to not only pull back the usual numbers required for modelling, such as your removals, your cancellations and discharges, but given you'll be running multiple scenarios, you will need to be able to identify scenario-specific values to support your assumptions. This may involve running the metrics for specific subsets of normal service, if you're only going to restore, for example, urgent patients or certain conditions. On top of that, you're going to have a look at what events have happened as a result of the shutdown of the elective service that are going to skew your figures. If you are like us, you had mass cancellations of your appointments and your theatre lists. If you're not careful, your modelling will be skewed by those key events. So you have to identify when they happened and whether you can normalise those or exclude those from any of your calculations. So working with your informatics team is going to be key. And finally, we have patient behaviour to consider. One person walking through the door is unlikely to be the same as the next person. So depending upon the service that's being restored, the behaviour is likely to be different, and we will need to consider factors such as mobility and accessibility. Will they be accompanied by carers? Will they have partners come with them? Or are parents going to be turning up? Are they going to need interpreters? Will they need British Sign Language staff? Will they need all sorts of other things that in the past you've just provided without really thinking about it? Now they're going to become key because they are going to have an impact on PPE requirements, accessibility and social distancing. Now, depending upon the service that's being restored, the clinicians involved should be able to give you some sort of key ideas as to the numbers around this. So if you're restoring a geriatric service, for example, they are going to be able to tell you that 95% of those people that turn up will turn up with a partner. 30% of those will probably be in a wheelchair, which is going to be pushed, or might be in their own scooter. And these are the sorts of things that you're going to have to bear in mind, because one patient turning up is technically now 2 pieces of PPE that is required. So adding to your PPE requirements is going to impact on your ability to maintain social distancing, because you're going to have shared waiting rooms, you're going to have small consulting rooms. Obviously, if they do turn up in wheelchairs or using mobility scooters, they may well need other routes of travel or different waiting areas because of the space requirements and the inability to manoeuvre safely whilst social distancing. So all of these are going to feed into some of the ideas you've already had and things that we've already mentioned, and you'll have to work with estates to actually look at these sorts of things. So up to this point, I focused on capacity being key. Capacity is the driver. This is true for most services you're going to be looking at restoring. However, for certain support services, capacity is one service, also capacity in one service will translate to demand in another. Be it patient or staff testing, endoscopy or imaging, the capacity is going to evolve into demand when multiplied by the relative conversion rates identified. Apologies for my dogs. They're now going to sit in the garden for a while. So capacity is going to evolve into your demand when multiplied by the relative conversion rates that are identified through working with your informatics team and that are specific to the services that you're restoring. Obviously, you will apply this to the various scenarios that you do have, and you'll be using various assumptions, and this will give you some sort of feeling as to what is actually happening. Each of these various models for service restoration can then feed into the equivalent models that you will have developed for your diagnostic services, thereby identifying where extra capacity is going to be needed to be brought online to meet the expected demand and informing of any potential delays when restoring services beginning sending patients through to the hospital. It's also going to help identify when a restoration plan is overreaching the available capacity for testing, which could result in diagnostic services being overwhelmed, thereby impacting on the ability of other restored services to operate within their agreed frameworks. We should never be in a position of having to cancel patient admissions because delays created through pressure on the testing process have meant that the results of their pre-admission swabs are not available. That effectively is the line that we should not cross. So it's all about collaboration. Restoring a hospital to some degree of normal service requires input from everyone, and if done correctly, it can benefit everyone. So as I've previously covered, you will be in a position to calculate your expected PPE usage. This can be used to feed into procurement plans for future processing. future purchasing, as well as financial costing models, which may lead to framework agreements and cost benefits to the trust through cooperative purchasing arrangements. Stores will be in a position to ensure stockpiles are maintained in the correct areas and in the correct volumes to maintain continuation of services. Estates will be in a much better position to handle the increased volume of potentially contaminated waste, thereby keeping corridors and cupboards free from piles of bags as more and more services come back online. They are also going to need to increase their on-site storage for this contaminated waste prior to collection and disposal, and may be in a position to change any sorts of framework agreements on how your waste is handled based upon the volume that's going to be created. I covered earlier how you can record critical resources that may need decontamination at the risk of reducing your available capacity. Knowing this information and the impact on service delivery of a calculated downtime can feed your business plans for surplus equipment to fill in those gaps and keep services running at a maximum level. If the kit is going to be taken out of circulation for cleansing, but you can identify the volume that is required to replace that kit, you can effectively maintain 100% of your delivery by just rotating the equipment in and out. And then finally, we have the ultimate aim for the use of the capacity numbers. It should be possible to build a virtual model of your hospital and feed in each of the capacity elements in a restoration plan to accurately model minute by minute, hour by hour, day, week and month, the patient flows within your trust. Doing this will allow you to potentially identify actual pinch points within your corridors. Pinch points which are by their very nature are going to increase the risk of social distancing breaches and provide potential for contamination. This would provide a checksum against restoring a new service in an area that cannot cope with the resultant patient volumes. So mapping the patient flow from the different services to use different entrances and exits, restrict the corridors they can use and direct them to allocated car parking, could in effect create modular delivery systems that would continue to work if breaches of contamination occurred in one area, because you've effectively insulated them from the surrounding estate. Therefore, if anything did happen, you might not have to shut down your whole hospital. So if any of your organisations already possess simulation software, I would suggest you begin discussions with whoever runs that and see if you can actually gain access to that and how it can be used to help with your plans. If you do not, but you do have close working links with either your local council or universities, then it may be worthwhile speaking to them, because they will use simulation software of some sort or traffic management software to model highway services. And with a little adjustment and the plans of your hospital, you could create a virtual map to work with. And hopefully then, as more and more services are restored, you can add in these numbers and you can start to work out where potentially you have a risk developing and be ahead of the potential for an outbreak by putting in mitigating processes. It is a bit of a leap, but hopefully if it does work that way, that would be perfect. So as I said before, I must add that this is a step beyond anything anyone will have done before and anyone will have considered. So it may be out of the reach of a lot of organisations, but it does help reinforce the fact that data collected for D&C modelling can do so much more than just be used in D&C modelling. So I hope you found this useful, and I'd like to take this opportunity to wish you the best of luck in restoring your hospital services to whatever you decide is the new normal. And thank you.